Welcome to our third and last video on chest trauma. Let's begin. In this lecture, we'll discuss flail chest and penetrating chest injury. For each of these conditions, we'll cover general characteristics, etiologies, clinical features, diagnosis, and management. Let's begin. A flail chest develops when a portion of the rib cage breaks and becomes separated from the rest of the chest wall. This is defined as at least 2 fractures per rib and at least 3 adjacent ribs. Now let's break down what is happening during inspiration in patients with a flail chest and a normal chest to determine the mechanism of paradoxical chest movement. During normal inspiration, diaphragmatic contraction leads to the pulling of the rib cage out by intercostal muscles. Thus, the pressure in the thorax decreases below atmospheric pressure and air enters the lungs. During normal expiration, diaphragm and intercostal muscles relax and allow air to move out of the lungs. On the other hand, in patients with flail chest, the flail chest segment is sucked in with inspiration and ballooned outwards with expiration. Since the flail segment of the chest moves in the opposite direction to the rest of the chest wall, it is called paradoxical movement. Now let's talk about etiologies. Most commonly, flail chest results from blunt trauma such as motor vehicle collisions and falls, especially in the elderly population. Another important risk factor is chest compression when the chest is caught between 2 objects. Typically, patients present with dyspnea, pleuritic chest pain, tachypnea, and tachycardia. On physical exam, paradoxical chest wall movement is detected during breathing. We've already described the paradoxical breathing, but you should also know that this sign often presents later in patients with flail chest as the intercostal muscles fatigue, so absence of paradoxical motion does not exclude flail chest. Let's move on to a discussion about the diagnostic approach. Initially, on clinical exam, one may see bruising, feel crepitus on palpitation, and paradoxical chest movement along with rapid shallow respiration. The next best step is to perform a chest X-ray or CT, which usually depicts the number and location of fractured ribs. Even though laboratory tests cannot confirm the flail chest, they can help in the management of the condition by determining its severity and need for mechanical ventilation. Hence, arterial blood gas measurement, ABG, is recommended. Here you see a chest X-ray depicting multiple rib fractures, characteristic of flail chest. Note that on chest X-ray, you may have multiple fractures of 3 or more ribs. Here we have 3D reconstruction of a chest CT in a patient with flail chest. Each of the red arrows represents a rib fracture. You should be able to see how these multiple rib fractures in the contiguous rib leads to a section of the rib cage that is unattached to the rest of the ribs. This piece is then able to move as its own separate piece, which is why you may see paradoxical chest wall movement. Finally, let's talk about management. The primary goal of management is adequate pain control, so that the patient can contribute to their own breathing as much as possible. If needed, the patient may need respiratory support via positive pressure ventilation to improve tidal volume and blood oxygen levels. It is important to observe the patient for possible complications such as pneumothorax and use tube thoracostomy as needed. Surgical internal fixation of the ribs can be helpful for the reduction of ventilatory support and is preferred before intubation. However, if the chest trauma is severe, patients may require intubation. Lastly, patients should undergo rehabilitation with chest physiotherapy, which leads to better clearance of secretions and strengthening of muscles. Physiotherapy includes coughing exercises, resistance exercises, trunk exercises, and chest wall repositioning. A patient is rushed into the emergency department with trouble breathing following a motor vehicle accident. Initial chest X-ray shows fractures in ribs 4 through 6 on the patient's right side with 2 fractures per rib. What is the characteristic physical exam finding likely seen in this patient? Describe how this exam finding appears. This patient presents to the emergency department following a motor vehicle accident and complaining of dyspnea. Based on the chest X-ray finding, you should be able to diagnose this patient with flail chest. Remember, to meet the criteria for flail chest, the patient must have 2 fractures per rib and at least 3 ribs, which this patient has. Next, you have to remember that the characteristic physical exam finding in flail chest is paradoxical chest movements, meaning the chest wall will move opposite that of a healthy patient during respiration. This means that when the patient inhales, the chest is pulled inward instead of outward as it would in a healthy patient. Additionally, when the patient exhales, the chest wall will be pushed outwards instead of inwards as we would expect with normal respiration. Now that we have reviewed flail chest, let's move on to discuss penetrating chest injury. Penetrating chest trauma injures the vital structures involved in the chest via various mechanisms, including gunshots, stab wounds, or accidents that create open chest wounds. In this lecture, we're going to pay attention particularly to hemothorax, pneumothorax, cardiac tamponade, and pneumomediastinum. Let's take a minute and understand the mechanism of injury behind each of these. Hemothorax develops from blood accumulation in the pleural space, which in turn prevents gas exchange and can lead to hemodynamic instability as significant amounts of blood can accumulate in the pleural space. Usually, bleeding happens due to either intrapleural or extrapleural causes. For example, if the great vessels of the heart are injured, it results in profuse intrapleural bleeding and massive hemothorax. Extrapleural bleeding can lead to hemothorax too, such as when the intercostal arteries are damaged and bleed. Another common outcome of penetrating chest trauma is pneumothorax, which is typically caused by a penetrating wound that allows air entry into the chest. For example, if a lung is stabbed, air can leak out from the lung into the pleural space. Thus, pressure increases in the pleural space and causes atelectasis and collapse of the lung. At the same time, as pleural pressure continues to increase the side of the injury, mediastinal structures can shift to the uninjured side and compromise that lung as well. Next, cardiac tamponade is the result of a stab wound to the heart and leads to accumulation in the pericardial sac, which leads to cardiac compression and decreased cardiac output. Lastly, pneumomediastinum develops when air escapes from the lung or abdomen into the mediastinum. Now let's talk about the clinical features of each of the previously mentioned medical conditions. Patients with hemothorax may present with signs of hypovolemic shock due to significant blood loss and tracheal shift to the opposite side as blood accumulates in the pleural space. Usually, on percussion of the affected lung, dull sounds will be found due to fluid accumulation. On the other hand, patients with pneumothorax present with respiratory distress, decreased breath sounds, JVD, and tachycardia, along with narrow pulse pressure and tympanic sound on percussion. So as the pleural pressure on the affected side increases, it leads to a mediastinal shift to the opposite side, which in turn results in compression of the uninjured lung and superior vena cava, leading to decreased preload. Hence, decreased preload to the left ventricles leads to the decreased cardiac output, poor systemic perfusion, and hypotension. Overall, you get both respiratory distress and cardiovascular compromise, which manifests as these clinical features. Now moving on to cardiac tamponade, also known as hemopericardium. This is associated with the Beck triad, which consists of JVD, hypotension, and distant heart sounds. On ECG, we typically see electrical alternance due to swinging of the heart in the fluid-filled pericardium, which leads to various different amplitudes of QRS complexes. Patients with pneumomediastinum usually report pleuritic chest pain, shortness of breath, along with Hammond sign, which is a crunching sound on auscultation. Here's an ECG showing electrical alternance. Notice the alternating QRS amplitude in most of the electrical leads. Again, this is seen in cardiac tamponade because of the swinging of the heart in fluid-filled pericardium. Now let's discuss the diagnostic approach. To begin with, ensure the patient does not need emergent intervention by performing the primary trauma survey to evaluate for airway, breathing, and circulation. As long as the patient remains stable, full evaluation, including laboratory tests such as arterial blood gas and CBC, can be performed. In terms of imaging, a fast ultrasound exam is a quick diagnostic tool for patients with chest and abdominal trauma, giving the results within minutes. A fast exam typically looks at the right upper quadrant, left upper quadrant, heart, and bladder to examine for any fluid in these areas. However, the lungs can also be examined with an extended fast exam, which can detect a pneumothorax. This can be used to quickly evaluate patients that are not stable enough to wait for a chest X-ray or CT scan. A chest X-ray remains the primary diagnostic tool, followed by a CT scan, which is better at detecting different types of fluid in the chest cavity. Lastly, an echocardiogram is a very useful tool to evaluate the damage to the heart and aorta. Here is a chest X-ray which depicts a tension pneumothorax on the left side, characterized by a large area devoid of lung markings, tracheal deviation, and movement of heart away from the affected side. Note that all these findings are the consequence of the gas accumulation in the pleural space, resulting in a compression of the mediastinal structures. Here you see a chest X-ray depicting cardiac tamponade with characteristic water bottle-shaped heart. Note that the cardiomegaly on chest X-ray suggests pericardial effusion. Here is an ultrasound of cardiac tamponade. You can notice the presence of clear space between heart and pericardium, suggestive of the presence of fluid in the pericardial space. Finally, let's talk about treatment. As usual, the management of any trauma patient starts with the ABCDE system. It is important to first make sure that patient's airway, breathing, circulation are intact. If a patient presents with signs of a tension pneumothorax, such as pleuritic chest pain, absent breath sounds, distended neck veins, hyperresonance, and hemodynamic instability, immediate needle thoracostomy or tube thoracostomy should be performed without chest X-ray imaging. If a patient presents with signs or symptoms of cardiac tamponade, the best initial treatment option is pericardiocentesis through the fifth intercostal space. Don't forget about ongoing resuscitation with IV fluids in patients who are hemodynamically unstable. On the other hand, stable patients can undergo an echocardiogram that is a fast, non-invasive, and accurate test for pericardial fluid detection. Depending on the severity of the chest trauma, observation, sternotomy, and thoracotomy can be done. Particularly, the last two procedures are very useful in patients with great vessel injuries and massive hemorrhage. During a play rehearsal, an actor is accidentally stabbed in the right upper chest with what was assumed to be a fake spear. On chest x-ray, there is an absence of pericardial lung markings on the right side and the trachea is shifted to the left. Based on the type of injury and chest x-ray findings, what would be expected on auscultation and percussion of this patient? In addition to bad luck, this patient has a penetrating chest injury that has allowed air inside of the pleural cavity, thus making the intrapleural pressure equal to the atmospheric pressure and collapsing the right lung. This is the definition of a pneumothorax. The chest x-ray findings of absent peripheral lung markings help to distinguish this injury from a hemothorax, which we would expect to show opacification of the thorax on the affected side, secondary to blood accumulation. On auscultation of a pneumothorax, since the right lung is collapsed, we would expect decreased or absent breath sounds on the right side. On percussion, since the right lung is deflated and there is significant amount of air in the chest, we would expect to hear a louder tympanic sound, much like hitting a drum. This is in contrast to hemothorax, where one would expect to hear decreased breath sounds and dull sounds on percussion. Let's summarize the approach to the patients with chest trauma by using this algorithm. As we've already mentioned, in all patients, including the ones with penetrating thoracic trauma, a primary survey with ABCDE system should be performed. So according to this system, you assess airway, breathing, and circulation. Hence, if a patient has compromised airway, suction, head tilt, chin lift, and jaw thrust should be done. In addition, consider intubation unless tension pneumothorax or cardiac tamponade is present, in which case symptoms are going to be worsened further by increasing pressure in the airways. The management of compromised breathing presented by dyspnea and decreased O2 saturation will be discussed on the next slide. Now let's move on to circulation assessment. If it is compromised and patient presents with hypotension and active bleeding, perform an EFAST chest x-ray, EKG, troponin. After primary survey, if Beck's triad, JVD, distant sounds, and hypotension, is present along with electrical alternans on EKG, water balloon heart on chest x-ray, or fluid surrounding heart on EFAST, suspect cardiac tamponade. When patient with cardiac tamponade is hemodynamically stable, proceed with echocardiogram, chest CT, and surgical consult, while when patient is unstable, perform pericardiocentesis right away. Now, moving on to the next scenario. If a patient has decreased breath sounds, pleuritic chest pain, tracheal deviation, meniscus of fluid, blunting of costodiaphragmatic angles, suspect hemothorax. Stable patients get further evaluation with chest CT and surgical consult, while unstable ones get thoracostomy. Lastly, let's discuss the patient with nausea, vomiting, chest wall bruising, pain, arrhythmia, ST changes on EKG, along with increased troponin levels. If a patient is stable, proceed with TEE, while if a patient is unstable, perform TTE. In the case of RV dysfunction, proceed with oxygen therapy, chest tube placement, cardiac telemetry, ACLS protocol, or surgical consult based on severity. Now let's take a look at the patient with chest trauma who presents with difficult breathing. If a patient has compromised breathing, presenting with dyspnea, decreased oxygen saturation, there are three etiologies we have discussed in this lecture: flail chest with or without pneumothorax, diaphragmatic rupture, or pulmonary contusion. Let's go through each of them. When there is a paradoxical chest movement along with absent breath sounds and hyperresonance, perform chest x-ray in stable patients. If a patient is unstable, directly assume that they have flail chest with or without pneumothorax or tension pneumothorax. In terms of management, if a patient has tension-type pneumothorax, perform needle decompression. If a patient has simple pneumothorax, perform tube thoracostomy, and if there is a flail chest, give analgesics, PPV, and surgical internal fixation. Now let's move on to a patient with bowel sounds in the lung fields, scaphoid abdomen, abdominal pain, and nausea vomiting. If hemodynamically stable, perform chest x-ray, which usually detects elevated diaphragm along with gastric colonic bubbles and lung field. If still inconclusive, proceed with CT. In the case of instability, perform EFAST, which typically shows large tear through the diaphragm along with eviscerated organ. Both testing strategies lead to the diagnosis of the diaphragmatic rupture. In terms of treatment, perform NG tube decompression, give IV fluids, analgesics, and proceed with surgical repair. Finally, let's pay attention to the final scenario about a patient with wheezing, bloody sputum, and decreased breath sounds. If a patient's symptoms presented within 24 hours, perform CT scan. If symptoms presented within greater than 24 hours, perform chest X-ray. Irregular areas of consolidation on chest X-ray and focal areas of edema hemorrhage on CT leads to the diagnosis of pulmonary contusion. In terms of management, give oxygen therapy, CPAP, BiPAP, analgesics, chest physiotherapy, and optimal positioning. A 48-year-old man is brought to the emergency department with a stab wound to the left side of the anterior chest wall. He was involved in an altercation when somebody stabbed him with a knife. The patient is alert to time, place, and person, but is moaning in pain. Vital signs include a temperature of 37 degrees Celsius, blood pressure of 80/50, heart rate of 150, and respiratory rate of 25. SaO2 on room air is 97%. Physical exam reveals jugular venous distension and distant heart sounds. A bedside ECG shows low voltage QRS complexes with alternating amplitudes. What is the best next step in the management of this patient? A. Pericardiocentesis. B. IV normal saline. C. Chest tube placement. Or D. Intubation. This patient presents with a stab wound to the left side of the anterior chest wall. He is alert to time, place, and person, but is moaning in pain. The patient is hemodynamically unstable, evidenced by the blood pressure of 80/50, a heart rate of 150 beats per minute, and respiratory rate of 25 breaths per minute. The physical exam reveals jugular venous distension and the distant heart sounds. This patient has Beck's triad, which includes hypotension, jugular venous distension, and muffled heart sounds. Beck's triad is characteristic of cardiac tamponade. A bedside ECG shows low voltage QRS complexes with alternating amplitudes. This sign is known as electrical alternans and is pathognomonic for the cardiac tamponade. The best next step in management of an unstable patient with cardiac tamponade is emergent pericardiocentesis. Pericardiocentesis relieves the external pressure on the heart chambers and restores the end organ perfusion. Therefore, the correct answer is option A. Here's a slide reminding us of the management of tension pneumothorax and cardiac tamponade. Let's discuss why other options are incorrect. Option B is incorrect because although intravenous normal saline is promptly administered in the emergency department to maintain the end organ perfusion, this patient is unstable and requires immediate stabilization with pericardiocentesis. Additionally, the patient's low blood pressure is a result of fluid in the pericardial sac compressing the heart, decreasing cardiac output. Normal saline will not impact the cardiac output and will therefore not impact the blood pressure in this patient. The only option to improve their cardiac output is to remove the fluid to improve pumping function of the heart. Option C is incorrect because chest tube placement is used to treat pneumothorax, hydrothorax, hemothorax, and chylothorax. It is not useful in the management of cardiac tamponade. Finally, option D, intubation, is incorrect because this patient has a secured airway evidenced by the normal oxygen saturation value of 97%. And that concludes our lecture on chest trauma.